and it looks like, well, more people will join, and Nicholas will admit them as soon as he can. So I will now get started. Thank you very much for joining Department of Psychiatry Grand Rounds today. This is the second to the last Grand Rounds of our season before we take a break during the summertime. Next week is our final one, and our chair, Matt State, will be presenting Grand Rounds. Today, we are very fortunate to have one of our own UCSF colleagues as a special guest to present. Dr. Paul Volberding will be introduced by Jim Dilley in a moment. Before I turn the mic over to Jim Dilley, a couple of other housekeeping things, and that is please feel free to submit questions during or near the end or at the end of the presentation, and please send them to Jim Dilley. In your chat function, send a private message to Jim Dilley directly. If by chance I get a stray one, I will re-forward it to him, but all questions go to Jim. It is my unique pleasure to to welcome you all and to introduce Jim, who will introduce Paul Volberding. Jim and Paul were my both contemporaries and role models. All of us got our training and early careers starting in the late 70s and 80s at San Francisco General, UCSF at large. And it was just amazing to see these two individuals take on the enormous task of challenges with the then emerging, what's turned out to be HIV and AIDS, with Jim establishing, with the support of John Hopkin, who was then the chair of the San Francisco General's Department of Psychiatry. That was just as San Francisco General was entering the fold of UCSF. And in fact, I think Jim was one of the very last residents of the SFGH specific program, and I was the first in the class of the residency that integrated San Francisco General with Mount Zion, with the existing VA UCSF Langley Porter residency. And that was a time of great change, and there have been continuous major changes throughout our careers. So welcome to Jim, who will now take the mic.
Thank you, Lowell. Everybody can hear me. Welcome. Let me just begin by saying Dr. Paul Volberding is really very simply one of the world's foremost experts in the care and treatment of those with HIV/AIDS. And of course, now most of us think about the HIV/AIDS epidemic as the first pandemic, certainly of our lives. He came by this reputation honestly. He was an active care provider, researcher, and educator since the very early days of the epidemic. He also lobbied for, helped create and maintain a system of AIDS care that really became the envy of the world, all the while leading HIV research at San Francisco General. He spoke widely about care and treatment, edited one of the earliest textbooks on AIDS, conducted clinical trials on different medications, authored or co-authored over 200 journal articles, including one with me in 1985 that was published in the Green Journal, our American Psychiatric Journal, which was, I think, number 28 on a list of over 200 articles that Paul has either authored or co-authored, and has been active nationally and internationally. I know all of this because, not only because I could read his CV, but also because I was there and worked with Paul and others during this entire time to champion the mental health needs of patients with AIDS and their support networks. I actually met Paul a few years before the epidemic, actually in 1979, as Lowell was mentioning. I was a newly minted intern at the Department of Psychiatry's program at SFGH, and Paul was a UCSF fellow in medicine and oncology, and happened to be an attending on one of the medical teams where I was an intern. And for those of you who are doing the math, yes, that is 42 years ago. He was then, as he is still today, a terrific role model. He has his calm, easygoing manner, his commitment and respect for his patients, and the passion for his work was extended to those of us who were even lowly interns at that time. I didn't see him again until 1983, when as a senior resident on the CL service at the hospital, the hospital began to see more and more of these young, previously healthy gay men who were being admitted with, at that time we referred to them as fever of unknown origin, or FUO patients, and shortness of breath, many of whom needed intubation, and many of whom died within days of admission. Sound familiar to what's happening today? It took several years for the complete picture to fully come into focus, but fear and uncertainty certainly ruled the day. I again ran into Paul then, who was at the time chief of medical oncology and was focused on Kaposi's sarcoma, the cancerous lesion some of the AIDS patients had, and soon became recognized as one of the signs of AIDS, and asked Paul if he would support my doing some follow-up psychiatric work on Ward 86, the outpatient AIDS area, and he agreed, and we established what is now would be referred to as an embedded mental health clinic on Ward 86, and it has been there ever since. Today, Paul serves as the Associate Chair of UCSF Global Health. He directs the UCSF AIDS Research Institute, a position he's held since 2012, and is the PI on a 5-year funded center grant for AIDS research. He continues to provide direct patient care, mentors young clinicians, and continues to be an outspoken advocate for those with HIV. So thank you, Paul, for being here today, and really thank you for all that you've done for the care and treatment of people with HIV.
Jim, I can't imagine a nicer introduction from somebody that I respect and have worked with so long. It's really an honor to be here.
Thank you.
A little bit of a background. I was asked to put together a grand rounds for the Department of Urology a couple months ago, but I had been asked way back in the fall, and between when I was asked and when I actually gave my talk, which is pretty much what I'm going to be giving today, COVID happened, and our world changed in ways that we obviously don't yet fully understand and can't really anticipate. So I would see this as a talk where we kind of noodle around some of the issues that are already obvious, but expecting that things are going to change dramatically. And then when we think things are as bad as they could possibly get, we had the events of the recent weeks with the murders of Black men at the hands of police. I went to medical school in Minneapolis. I know the neighborhood where the events happened, and it's I just got notice that the School of Medicine is having a special town hall later this afternoon at 5:30. Open to the community to discuss some of the issues, and I would urge everyone to take part in that. So let me share my screen if I can. And I will load a slideshow. Is my slide showing?
Yes.
Okay, great. So I'm going to rather quickly go through some aspects of the history of AIDS. I'm going to focus really a lot, for obvious reasons, at what happened in San Francisco. My first 20 years on the faculty, and I'll really not directly talk about the COVID epidemic until towards the end, but as I go through the history of the HIV epidemic, I think you'll see some obvious parallels, but also some obvious differences. So as we start, I think it's kind of interesting that, HIV is the virus and AIDS was the disease, that, as we called it. And here again, we have a virus name and a disease that's separate. And the virus is SARS-CoV-2. The disease is COVID-19. I'll be sloppy and probably interchangeably use COVID-19 as the name of the virus. It's not that I don't know better, but it's just easier. So what I'd like to do in the time we have today is really very briefly talk about the perspective of the HIV epidemic here in San Francisco. I won't really talk about the global epidemic, although it's very important and UCSF is very involved in responding. And then I'll talk about the current response here to the coronavirus pandemic. UCSF again is, and I take zero credit, UCSF is playing another leading role in responding to what we're faced today. And then at the end of my talk, I'll compare the two epidemics and talk about maybe some lessons that we might have learned. To start with, I would urge, because I recognize that a lot of the people on the grand rounds today weren't around in the early AIDS epidemic. Randy Schultz's book. Randy was a journalist, one of the first journalists that really decided to talk about the AIDS epidemic. He wrote a book, and the band played it on. It's really wonderful, and I think it does give you a sense as you read of what it was like in those early days. Randy died himself of AIDS in 1994. Now, the first report that we heard, and I admit I didn't notice this when it came out. This was in June 1981. I started at San Francisco General Hospital on July 1st, 1981. But even before I started, a couple weeks earlier, there was a report from Los Angeles of a small cluster of people, gay men, with a very unusual pneumonia, pneumocystis carinii pneumonia, and this was really the warning signal that our world then was really about to change. This is not the first patient that I saw on my first day as a faculty member at San Francisco General Hospital. I have not got his family's approval to show my photo of my first patient, but this is a fairly typical Kaposi sarcoma patient from the early epidemic. This is a cancer that, even though I was a recently minted oncologist, I had really not studied, didn't know, had never seen a case before. And when I was rounding on my first day on July 1st, we saw a patient with KS, a 22-year-old gay man. My fellow at the time had just arrived from New York City, and he said, I think we saw some of these there. And so immediately there was a network building of physicians and others that were beginning to recognize that something was happening and that a new disease had emerged. How did it happen? How did it spread? Here, I think we'll have some parallels with what we're seeing today with SARS-CoV-2. HIV jumped to humans from chimpanzees. It's a chimpanzee virus. We don't know exactly when it entered humans. It was probably quite a while ago, probably at least in the earlier mid-20th century. It started in West Africa. It was initially not appreciated to have happened, but with urbanization, it spread to East Africa, where it really took off, and it became a concentrated epidemic for the first time in Uganda, where a number of people at UCSF have major research and care programs. I like this old newspaper. It isn't really accurate anymore, but it does make the point that that HIV, once it appeared, as do all epidemics, use the most rapid transportation available. It got on passenger jets. It made its way around the world. And in fact, we know now with some very sophisticated genetic work that it arrived in New York City from the Caribbean, In about 1972, the virus arrived in San Francisco. We know pretty exactly in 1976. And just think of that compared to what we've learned now with COVID-19, which arrived probably in the Bay Area within weeks of its emergence in China. The current pandemic. Lots of reasons for that, but a very amazing situation. Now, I showed this slide. This is an ancient slide I've been looking at for the last few decades. This shows CDC reports of AIDS cases. At first, we didn't have the ability to test for HIV, so we reported to the CDC just the end stage manifestation called AIDS. And each dot is 20 cases of AIDS, and you see what I used to say, that AIDS spread very rapidly. But if you look at the time frame of this, this is spreading over a decade. Contrast again what we've seen now with the spread of SARS-CoV-2, where this is happening in the matter of days or weeks. But it did spread. And as you can see, it didn't spread uniformly across the country. Again, parallels with what we're seeing today. But San Francisco, Los Angeles, and New York, and other major cities were foci of the early AIDS epidemic. Now, one of the things that's not appreciated, I think, as much as one might think, is that HIV really is it's an amazingly bad virus. It's bad because there's a silent phase of infection that can go on for 10 or more years, during which time the virus can be spread. But untreated, HIV is actually the most lethal infection that we've ever seen. 98+% of people, if you don't treat HIV, will die of AIDS. It's worse than Ebola. It's obviously worse than the flu or COVID-19 in terms of its lethality. But again, it's a disease that is not uniformly affecting the entire population. And one of the major differences when we compare the impact of HIV and the impact of COVID-19 is the fact that in the case of HIV, most people weren't really at high risk. And with COVID-19, obviously, we are all at probably comparable risk of infection. But AIDS very quickly became a major killer of young people, especially young men. And you see on this slide that by 1991, it was right up there with unintentional injuries. Now, as Jim said, there was a vigorous response, especially in San Francisco. It was called the San Francisco model. I think there are elements of it that were happening probably everywhere. But I'd like to just really briefly consider the response to the medical community, the response in the affected populations, and the political response, each of which were important elements in this model that we had. Now, the medical response really UCSF and especially SFGH played a huge role. Every hospital wasn't equally affected. San Francisco General Hospital, as a safety net hospital, assumed responsibility immediately, as it always has for emerging infections, as it did with tuberculosis, yellow fever back in the day, and the case with HIV. Now, this is a person that I know well. Molly is my wife, but Molly is an internist, was a chief resident at San Francisco General Hospital from 1980 to 1981, with another person who became really a star in infectious disease, Chip Chambers. And what she talked about at that time was that they would hear of these cases, unusual cases of infections, and they didn't know what was going on. The term AIDS no one had put it together, but they were seeing cases before that MMWR report, and showing again how a hospital like SOGH, which is at the front lines, where people are thinking about these unusual cases, became the start of the AIDS epidemic. Now, Molly was serving as chief resident under the brand new chief of medicine, Merle Sandy. Merle Sandy is an infectious disease person. He was at the hospital. Died of myeloma, but Merle was really one of the early infectious disease experts. And just as an aside, Tony Fauci was one of his interns at Cornell, where Tony trained. Merle was very supportive of the response to AIDS and played a major role in helping build my program, and I'll talk about in a minute the first AIDS inpatient ward 5B. Now, one of the interesting things to me in going back and remembering some of the early days is how quickly UCSF got organized around AIDS. A lot of credit to Marcus Conant. Marcus is a gay dermatologist. He was very well connected with the gay medical. As cases of Kaposi sarcoma in particular began to appear, again, very early, even by mid-1981, that this is something that we should be watching. And without any authorization from the university, Marcus put together an informal group that met weekly. And one of the strong features of this, and I'm not going to so much specifically talk about mental health issues, but this was multidisciplinary right from the start. And as Jim was saying, the medical care of patients certainly touched into the stresses that the patients were experiencing, the effects, and one contrast to I think what happened later, but is happening much earlier with the current COVID-19 epidemic, is that a target for the mental health issues includes all of the caregivers who are now obviously struggling mightily with what they're seeing. So we got together, we shared news. Members included some people who went on to amazing careers themselves. Jay Levy, who co-discovered HIV. Art Amon reported the first case of AIDS in an infant. John Greenspan described a unique clinical feature. So this was an important issue, and this is a photograph that I like because it shows me with hair, just to prove that I did at one point have hair. With Marcus Conant at the KS study group, probably in about 1982. So again, multidisciplinary response. At the general, the response was especially three of us, and I should add Gay Ling as I do on the words on the slide. Gay Ling G was the nurse who really put all of this together. But next to me is Donald Abrams, went on to be after me, the chief of oncology at San Francisco General, and Connie Wafsy. Connie was entrusted in the infectious disease aspects, and really the three of us put together some pretty amazing components providing healthcare for people with AIDS. Connie really tragically died of breast cancer in 1996, just when treatments for HIV became really quite effective. So we miss her. So where did we work? At first, actually, we saw patients in the rooms that the house staff used for sleeping at night on Ward 5B. We'll come back to 5B in a second. But when the numbers grew and when we became concerned about the possible risk to healthcare workers, the hospital found a space on Ward 86. It's the sixth floor of Building 80, and Ward 86. And we quickly occupied the entire floor. We took over a couple other floors. as the program grew. And really right from the start, as Jim was saying, this was a completely multidisciplinary effort. We decided that it made no sense to send patients to the psychiatry clinic, to infectious disease clinic, to GI clinic. Instead, we would, as the need arose, bring those specialists to Ward 86 to work. So we had a CMV retinitis clinic where the ophthalmologist came. We had a clinic especially serving the needs of the patients with dementia, which was an important problem. And once we moved out of 5B to Ward 86, the hospital then took 5B and turned it into the world's first AIDS inpatient unit. A really important component, and really right from the start, this was a nursing-led unit, but again, a place where Jim and the other mental health professionals, as well as community providers, would come to help take care of these really amazingly sick people. The community response, deserves its own full lecture, but it was amazing. And one of the immediate responses was from existing organizations, and one that I put at the top of the list was a bereavement counseling service based at Parnassus at first, but almost immediately as Marcus and I were seeing Kaposi's patients, one of the psychologists who was working with the Shanti Project, Paul Degg, basically helped turn the organization around to providing a full range of services, including counseling services for AIDS patients. In addition to pivoting of existing organizations, other ones sprang up. The San Francisco AIDS Foundation, newly created in response to the epidemic, and very many others. And I can't help but mention Project Open Hand. Molly ended up serving as the chair of the board for that organization, but that was a food service. The basement of the church by Ruth Brinker, and still to this day serves thousands of meals for people that are ill and need of food. And then finally on this slide, Martin Delaney, who started a group called Project Inform, which was again a community organization really aimed at delivering information. People were so hungry for information. And remember, this is before the internet existed, at least before we had access to anything like an internet. And the last of these responses in San Francisco focuses on AIDS and politics, and it's really important. And I think to this day, and certainly the reflections of what we're seeing with the current pandemic. The health department in San Francisco is an amazing organization. It's one of the most academically oriented. It's very connected with UCSF. Merv Silverman was the head at the time. And it was also really important that we had direct access to our community leaders. Diane Feinstein took an immediate interest in the AIDS epidemic, supported the growth of our program at San Francisco General Hospital. Had a little bit of a clash with Merv around the gay bathhouse issues, which maybe we could talk about in the Q&A, but still was a huge supporter of our program. And to this day, I respect both of these people, and they're both still with us. So a little bit of talk about the some of the dark side of the AIDS epidemic, and again, think of the parallels with the sensational press today with the pandemic. This was one from it looks like 1987. AIDS could end us all, and it never was really true, because the AIDS epidemic was much slower, much more confined than the current pandemic. But the concern that people had was really very, very strong. Now, if you see the movie, I should have mentioned it when I talked about Ward 5B. There's a really wonderful documentary that's now about, I guess, about a year old, called 5B. But it talks a lot about the struggles that the nursing staff had, especially around the issue, interestingly, today, PPE. Lorraine Day was the head of orthopedic surgery at the General, became really obsessively afraid that she was at risk and that surgeons would all die from AIDS, and insisted on this extreme PPE that most of us felt was over the top and really was a way of separating the provider from the patient, and that's featured in the documentary 5B. I urge you to look at that. But that issue did raise something that Molly did a lot of work with, which it raised the question of physician risk and responsibility in taking care of AIDS patients. We knew that we as providers were at some risk. The risk was mostly from unintended needle stick injuries, but Molly, in a really nice article that I'm sure you cannot find online, from a journal that no longer exists, from 1990, talked about the historical context of this concept that physicians and other healthcare providers have a special responsibility, pointing out that this question has been discussed for centuries, going back to the year, it's not a typo, 166, and up until 1793, when a yellow fever epidemic hit Philadelphia. And again, a statement there in a newspaper that said that we should consider healthcare providers basically like our military, that they have to assume some risk, because that's their professional responsibility. And obviously, more recently, we keep having epidemics emerge, and I think physicians have and nurses and other healthcare providers have really stepped responsibility. I'm going to really very quickly talk just a bit about treatment for HIV. It's really not that interesting anymore. I think the fact is that the investment in the basic science that was made resulted in the discovery of increasingly potent, effective drugs. We quickly understood the natural history of the disease. And I don't have the time to go through the many ways in which UCSF played a major role in this, but this I like this slide. When we first started having effective treatments, it was really cumbersome, quite toxic, and now we have a number of choices of what we call SingleTab regimens, where the person just takes one, almost no toxicity and almost uniformly effective. What happened as we got more effective treatment was mortality from the epidemic plummeted, along with the increasing use of these drugs. And I love this slide. Bay Area Reporter is a major gay newspaper in the area, and at the height of the epidemic, they would have these tiny little obituaries with usually a photograph of the person who had died, and they would have page after page of these tiny obituaries. And in 1998, for the first time in August, they noticed that they didn't have any obituaries to publish, and so they made that the headline of the paper, no obits. And again, think about that when we consider where we're going with coronavirus, and let's hope we can get to this kind of point as well. What are the similarities? And just the last few slides. I've already mentioned some of these. HIV came from chimpanzees, SARS-CoV-2 from bats. We talked about the global dissemination, which was fast in HIV, but it was much faster with the current pandemic. Transmission from asymptomatic infection is a major problem, and it's hard to believe. It's a mark of how recently we started working with coronavirus, but we still don't really understand the full spectrum of transmission from asymptomatic SARS-CoV-2 infected persons. We know it happens, but we need to know a lot more. The deaths in both diseases are horrible. As Jim was saying, you know, in AIDS, people died on ventilators. Most didn't survive an ICU admission, and we're hearing the same thing today. I think, you know, I remember being told at one point that during the 1918 flu epidemic, everyone in the world knew someone who had died of the flu. I think we're getting to that point pretty quickly with coronavirus, and I'm sure many of you already know people who have been affected and died of SARS-CoV-2. We had no treatment, we had no vaccine, and with AIDS we still don't have a vaccine. Hopefully we will have one for coronavirus. We lacked testing. We couldn't really do contact tracing. The events of transmission were so spread out over time, and there was a sense of isolation. The political leadership in both epidemics has been inadequate. As we well remember, Ronald Reagan didn't say the word AIDS publicly until 1987, 6 years into the epidemic. And I won't say anything about our current president. I think one might wish he not say as much as he does sometimes. But Tony Fauci, it's just remarkable. I think he was a strong voice in the early AIDS epidemic. He remains a strong voice even at 79. He's an amazing person. We hope he lives forever. There are differences in HIV. It turned out that everyone wasn't at equal risk. AIDS was a problem, especially in this country, in gay men and injection drug users. And with SARS-CoV-2, obviously, we believe we are all at similar risk, everyone. There was a very long asymptomatic phase in HIV. With the current pandemic, it's probably measured in a matter of days. That has important implications in terms of prevention. Containment and contact tracing really is possible with SARS-CoV-2. We saw that effectively deployed in China. It's not easy, but I think it certainly wasn't possible with AIDS. Mortality of HIV, as I said, was very high. Mortality of this virus, the coronavirus, is, you know, it's much less, although there are so many more people infected that we're seeing these staggering images of people. There was a risk to healthcare workers with AIDS. We did worry, but nothing like the current risk. And I think we're just beginning to see reports of the effects of stress and anxiety that will affect, and not just the physicians, but all the providers, all the people that are directly responsible for responding to the pandemic. We had primitive technology. Now with SARS-CoV-2, you know, the virus was identified and sequenced within weeks of first appearing. Our model of care in the AIDS epidemic really focused on the community. The current pandemic, the care is really focused on the acute setting and especially the intensive care unit. Very, very different type of organization to respond to. And HIV compared to what we're experiencing today. So I'll end with just a thought, more or less random lessons that we might have learned. We responded from planning and close connections between health leaders and political leaders, and especially the health department. That's a lesson that we still, I think, are applying today, and it's a very important one. We needed to have data on community prevalence with AIDS, and we certainly need that today with the coronavirus. One of the things that I think I and others have thought a lot about is that communication is really so essential. We tried to be available, calm, honest, able to admit when we didn't know something, ready to talk about what we had thought was true before, which was later shown not to be true. Avoiding false reassurance, and avoiding at the same time whipping up panic in the population. And again, we need to still learn that lesson clearly on a national level. We understood in HIV that it was the fear that drove a lot of the anger and demand for give me any kind of treatments back in the day. And we see the same thing, obviously, now. Chloroquine, even though it's been shown not to be effective, is still apparently in short supply for the people who really need it for medical reasons. We benefited from investing in basic science. We still do in this epidemic. And we are seeing the development of drugs and vaccines at a pace we couldn't have imagined. And I think part of that is because of the groundwork that was laid by activism from the AIDS epidemic. Last point is that healthcare was and remains this is a team sport, and I know the Department of Psychiatry has a variety of practitioners, and you are all needed. You will all be needed in responding to the current pandemic. So, Jim, it's been a pleasure coming and meeting the department. I look forward to the day when we can do it in person, but I look forward to any questions that we might have from the group. Thanks.
Great. Well, thank you, Paul. This was definitely a little bit like a walk down memory lane. Please remember, everyone, that if you have a question or a comment, to send it to me on using your chat function, and I'm going to basically moderate this next 10 or 15 minutes that we have left. Paul, here's a comment from one of the members of the audience. He writes, the closing of the bathhouses was an incredibly unpopular but probably needed public health message for reducing HIV transmission, just as shelter in place has been necessary for COVID transmission reduction. What can we learn from that experience in delivering successful public health messages to a public that is sometimes resistant to following them?
Well, that's a spectacular question, and it's a really centrally important topic then and now. I think part of the message is that behavior change is tough. We were talking about changing sexual behavior. That was hard. I remember Senator then Mayor Feinstein at one point just saying, "Why don't they just stop having sex?" We pointed out that it's not quite that easy, and at the time, the bathhouses were I think seen as really important symbols of the freedom that the gay community had achieved in the late 70s, early 80s, and that closing them was really like giving up a freedom, and clearly what we see with the current situation is that people don't like to give up their personal freedoms to not wear a mask and to assemble and to put themselves at risk. It's I think the parallels are pretty obvious.
Okay, good.
The self-right of this. He listened to the gay community. He listened to the political figures, and he kind of dithered a little bit to decide what to do. But finally, Feinstein forced him to close the baths.
Great. Let's see here. Do you have any concerns about inaccurate analogies being made between AIDS and COVID-19?
Well, I've tried, I hope successfully, to point out that there are huge differences, just very, very big differences. A lot of it is the transmissibility of COVID-19, the low mortality, the fact that the mortality is not apparently evenly distributed across the people that get infected. So there are major differences. I think some of them are worth talking about. I think maybe especially the importance of the connection between the medical and the public health and political groups. We need everyone to be working together. I think careful planning is important in both situations. But again, we're focusing now on contact tracing. And quarantining with SARS-CoV-2, we couldn't have done that. Certainly not at first, because we didn't have a test for the first 4 years of the AIDS epidemic. So we couldn't find people who were sick. And even if we could, their infection may have been transmitted to them 10 or more years previously from somebody they may not have known at the time. So it was impossible.
Paul, there are a number of questions about race and ethnicity as an issue between, and people are wondering if there is comments that you might make about the effect of race and ethnicity on both on HIV as well as on COVID.
Well, sure. There's so many ways in which medical issues and the social disparities that we see intersect. It's clear with any number of diseases. With HIV, there was especially an important role of stigma in the epidemic. There still is, and it's true that stigma drives people into hiding, and that's not good for public health. We need to have people being tested and being treated, and the same is true with the current pandemic. I don't think I think the issues are somewhat different, but what we're clearly seeing with COVID-19 is that the problems in our society, the disparities that have been with us for far too long, have resulted in a group of people who do have medical conditions at a higher rate, obesity, diabetes, pulmonary disease, disproportionately true in many of the Black and Brown communities in our country, and so I think when people with those conditions become infected with SARS-CoV-2, it seems as though they have a much higher risk of having a really bad outcome. And I don't think we fully understand the natural history yet, but I think that seems to be pretty clear. So it's really a question, and also, we've just been hearing about this recently, that you talk about social distancing, but if a person is a recent immigrant living in a 2-room apartment with 6 other people, and we've all seen some of these reports, you can't socially distance. You can't do that, and so. And again, so that is then another indication of the disparities that our society has, the health equities that really I would hope we can continue to insist on addressing.
Yeah, very good. I just happened to hear a piece on the news last night about an Asian guy living in a studio with three other men.
Yeah.
And so that's a point well taken. Paul, maybe you could talk a little bit about healthcare worker advocacy and HIV. I mean, HIV and the AIDS epidemic really spawned a lot of advocacy, both within the community at large, so you mentioned some of the community groups, obviously, who took on advocacy in a very significant and serious way, but also, healthcare workers also became advocates. You and I both, I know, had spent time in the mayor's office and the board of supervisors' offices, et cetera, et cetera.
Yeah.
And so I wonder if you might talk a little bit about that and what that was like.
Yeah, and that community vigils and community educational forums. It was absolutely so, and it's so to note that Larry Kramer died just a few days ago. Larry, his obits have been in the papers. Was just an amazing firebrand of a person, a gay man in Manhattan, who really took on AIDS as the rest of his life's cause in the earliest days. Said things that people didn't want to hear. Told gay men that they should stop having so much sex, and was really ostracized because of that. Started Gay Men's Health Crisis and ACT UP, New York, and fought Tony Fauci, but got services delivered to the community, and got the FDA to change their approach, got the drug companies to change their approach. So activism, it wasn't always as a healthcare provider, but it was really important. And I think as healthcare providers, you and I, Jim, we saw the need, and how could we not respond to that, both in terms of delivering care and insisting that better services be available. And credit Steve Morin, who was a psychologist who ran the Center for AIDS Prevention Studies, but who was also an important person in Nancy Pelosi's early days in Washington.
Right.
And really, people like Steve helped create what became the Ryan White Care Act. Still immensely important to reduce barriers to care. So activism among professionals was really important.
Yeah. Well, and certainly it's playing a role today, right, in terms of the COVID epidemic. I mean, the healthcare workers themselves, of course, without having PPE available to them, et cetera, there's really nothing left to do but become advocates for themselves, right? To try to move the needle in terms of helping them be protected.
Yeah. And I also, Jim, think of again, thinking of UCSF in San Francisco responding to the AIDS epidemic and now responding to COVID-19. And you see people just stepping up in amazing ways. George Rutherford, who's just amazing, telling the truth about what we know about the transmission and epidemiology, the work that's going on, led by UCSF, Diane Havler and others, to test populations, starting with the Mission and now Hunters Point and Bayview. So and working with the health department. So again, I think that's been really important and very positive.
Yeah. How about, Paul, you mentioned stigma. I'm curious a little bit about what you would see as sort of the role of homophobia in the whole epidemic of HIV, both on the, if you will, on the advocacy side, certainly, as well as on the clinical side.
Again, it's such an important and complicated topic. Stigma was part of the AIDS epidemic from the earliest days. Yeah. People, in many cases, would come to us with AIDS, with their families not knowing that they were gay, much less that they had acquired this disease. People in obituaries didn't mention that the person had died of AIDS, and it was just a huge thing. I remember at one point, one of my patients who was in a very committed relationship. If it were today, they would have been married. But when my patient died, suddenly, for the first time, his parents descended from the East Bay, got his body transported for burial, and wouldn't tell his partner where he was buried. The sense of shame and it was just so real, and it really has been an ongoing problem without stereotyping. I hope there are many in the African American community men who have sex with men who find themselves really so stigmatized that they really have a lower rate of testing for HIV than they should. And if you're not testing, then you're not taking advantage of PrEP and other prevention means. So still stigma is a problem. I gave in one talk, I mentioned this, and I said, well, stigma is not such an issue for COVID-19, but was pointed out that, in fact, that's not true. That Chinese Americans are in many cases being stigmatized, and there's an ageism that's stigmatizing people with COVID-19 as well. I think and I'm sensitive to this being probably a year older than you, Jim, or so, but there is this sense, well, if a person with COVID is old, they'll die. Kind of, so what?
Yeah,
as
right.
long as I, 24-year-old, won't die, why should I? It has to be addressed as well.
Yeah. Well, we're going to have to wrap up here in just a moment. But Paul, I wondered if you could also make a quick comment about vaccine possibilities in the age of COVID. As you mentioned, here we've been working on HIV for 40 years now,
Right.
more or less, and we have no HIV vaccine. What do you make of the current vaccine discussion about COVID?
Well, HIV is a very unusual virus, and there are many reasons why it's proving to be very challenging to create a vaccine. There's no such thing as natural immunity to HIV. It's not as though you get HIV, you get the antibodies, and then the virus goes away. Right. The virus keeps blasting of that occur. I think things are more promising for coronavirus. I don't know that much about the biology of vaccine development for coronavirus. My understanding is that, again, this coronavirus is not the only one. There are a number of them that infect humans and cause mostly just common cold. My understanding is that immunity is not a strong feature of that group of viruses, that immunity is partial and doesn't last all that long. So I guess if I were to guess, I would say that a vaccine is possible, but it's not likely to be super potent, and that it might require repeat administration. So the challenges for us logistically are enormous. How do you create a vaccine and distribute it to the entire global population? How do you deal with the fact that people for either strongly held religious or cultural reasons don't want vaccination, or are susceptible to the false information that's around from the anti-vax community? So I think my kids are going to be dealing with this for as long as they're alive. I think this is going to be a challenge for us in ways that we can't now anticipate.
Okay, well, with that, I think we're going to need to end. But I did want to remind folks that next week, Matt State will be giving the last grand rounds of the Psychiatry series. So, and I know that some information about that presentation will be coming out shortly. And so I want to thank everybody for coming this morning. I want to thank you, Paul, particularly for all that you've done and for your time with us here this morning. And with that, I think
great to see you again, Jim.
And good to see you too. Yeah. And I think we'll take it offline from there.
Okay.
Thanks so much.